Hello and good evening. Thank you, everyone, for joining us on your Friday evening for a California Thoracic Society educational webinar. We're going to give everyone about one more minute to log in, and then we're going to jump right in and get started so we can take advantage of the time we have together, but also not take any more time than necessary. Thank you for being here, and we'll get started in 1 minute. All righty. I just got the last group here logged in, so I think we're in great shape to begin this evening. Thank you again for being here on a Friday night. Hello and good evening. It's an honor to be here with all of you. Welcome to the California Thoracic Society Friday evening educational webinar series. Tonight's presentation was developed by the California Thoracic Society in collaboration with SmartVest by Electromed. Tonight's presentation is titled The ABCs of Bronchiectasis. Tonight's esteemed speaker is Dr. Samuel Louie. Dr. Louie is a professor emeritus at the University of California, Davis School of Medicine. He received his MD from the University of California, San Francisco in 1980, following his residency in internal medicine at the Wadsworth VA Medical Center and UCLA. He completed a pulmonary medicine and critical care medicine fellowship at the UC Davis, where he joined the faculty in 1986, retired in 2020, but thankfully returned to part-time clinical practice. His principal clinical research interests are in the area of drug safety and therapeutics in bronchial asthma, bronchiectasis, COPD, patient-centric management of these reversible obstructive airway diseases, and the evolving role and importance of non-paid caregivers. He is a reviewer for Chest and other journals. His book chapter, Status Asthmaticus, was published in the fifth edition of Principles of Critical Care in 2023. In 2011, Dr. Louie created the column Pulmonary Pitfalls for the Journal Consultant, including Lies, Damned Lies series. In 2021, Dr. Louie was given lifetime recognition for his achievements in medicine by the American Thoracic Society with the Outstanding Clinical Award. At the end of this presentation, there will be an opportunity for live Q&A. Please use the Q&A question functionality in your Zoom button interface. If you do send a message in chat, we'll see it and I can relay it, but it always helps us when your questions are in the Zoom Q&A. You're welcome to ask questions throughout the presentation if they come up or if it helps you remember them. We'll answer all of them live at the end. It is with great honor I now turn it over to Dr. Louie.
Well, Jason, I want to thank you for that introduction, and I want to thank you, the California Thoracic Society, President Laren Tan, and Dr. Nicholas Kenyon for nominating me back in 2020, I believe, or for 2021. That was quite a surprise, and I hope to carry this conversation on bronchiectasis. And I realize I'm in the way of a well-deserved weekend for all of you, so I won't delay any further. So we're going to talk about ABCs of bronchiectasis. And the title is not my choosing, but it's very elementary. But the topic, bronchiectasis, is deadly serious for patients living with bronchiectasis and quite challenging for clinicians like you and me to diagnose, treat, and manage. ABC is actually an old mnemonic for bronchiectasis treatment and management. As many of you know, A stands for antibiotics, B stands for bronchodilators, and C stands for cough harder. But a lot of patients can't cough harder or cough effectively. And our clinical experience and the published literature has taught us that, this is an oversimplification of the needs of our patients living with bronchiectasis. Morbidity, mortality with bronchiectasis continues to rise and is high compared to asthma and to COPD, surprisingly. And today, we recognize bronchiectasis as a chronic inflammatory lung disease, which is primarily neutrophilic, but can be eosinophilic. Serious morbidity, mortality arise from local as well as systemic consequences. And again, we can talk about bronchiectasis being a risk factor for lung cancer as well. But patients, they go through life suffering from a debilitating cough, copious sputum production, frequent exacerbations, and early death. So I'd like to really share with you 13 key points. And the first key point for this evening is that non-cystic fibrosis bronchiectasis is a clinical syndrome. It's not a single disease. It's very much like asthma and COPD. They're all syndromes. There'll be no discussion of bronchiectasis from cystic fibrosis this evening. We will restrict our discussion to non-cystic fibrosis bronchiectasis, or simply to save my voice, we'll call it bronchiectasis for the remainder of the program. Here are my disclosures, and I hope to prove to you at the end that I'm a patient advocate first. And here are the learning objectives. We're going to understand bronchiectasis pathophysiology as well as its pathobiology. We're going to understand the physics of airway mucus clearance when combined with pharmacotherapy and the need for interdisciplinary management. Patients with bronchiectasis need to cough more effectively, not cough harder, as many of you know from your clinical experience and expertise. We're going to identify airway clearance options, in particular, huff coughing and high frequency chest wall oscillation, and other considerations when managing these patients who live with bronchiectasis. We're going to understand bronchiectasis overlap risk factors with COPD, asthma, ABPA, non-tuberculous mycobacteria, uh, autoimmune diseases, you name it. But lastly, and most importantly, I want all of us to always ask, why not bronchiectasis? So we're going to, first of all, begin with an overview. And as many of you know from your clinical practice, your education, bronchiectasis is no longer a disease of orphanages. Many of you know it was first described by the father of pulmonary medicine back in 1819, uh, René Laennec, described it in an autopsy of several people who died from the consumption, among other infections, pulmonary infections. Very sadly, this year will be the 300th anniversary of the death of Laennec. He himself died from tuberculosis. Back then, it was known as the consumption. And based on a self caricature that I found in a book on medicine, he very likely died from bronchiectasis, given his emaciation. And as many of you who are experts in medical history, you know that tuberculosis was discovered by Koch in 1882. So back, in 1826, they didn't know what the consumption was caused by. Now, if you're British, you will pronounce, the word bronchiectasis, bronchiectasis. You put an emphasis on ECK. So however you want to pronounce it, this is really an anatomical description. This is the original description, but there's three working definitions besides the original anatomical definition. There's a radiological definition, but that requires clinical correlation. But more importantly, there's the clinical, and I think all of you listening in know what I'm talking about. That's the most important definition for our patients. Patients have to have symptoms and warning signs that they're not doing well, which is why, this term bronchiectasis, it's a matter of history, but I prefer, when I talk to my patients, I prefer to use this three-word phrase, chronic ulcerative bronchitis. I think I may offer a better description of what the patients have to deal with and explains to non-paid caregiver why these, lovely family members continue to cough and bring up all the pus. You know, the airways are not just abnormally dilated, there are bronchial wall abscesses. So again, it's very important, I think, to understand that there's enormous history. And if you look at the right-hand side of the slide, you'll see up on top an artist's rendition of a normal airway, a normal bronchial wall. And if you go to the bottom, I'm gonna see if I can use my arrow on my Mac. What you see here is a wholesale destruction of all the layers of the bronchial wall. As bronchiectasis typically will affect airways that are greater than 2 millimeter in diameter early on, but it can destroy lung tissue. And that's why we have a radiographical term called cystic bronchiectasis. But the mucus layer, the pseudostratified columnar epithelium, the lamina propria, the basement membrane, the smooth muscle, the cartilage can all disappear, leading to a severely damaged bronchial wall that you see. Where did my arrow go? Right there, right there. Yes, and this is, the reason why you get this dilatation. But there's also in many descriptions a airway constriction that can occur from fibrosis. So it's we think of bronchiectasis as a obstructive lung disease, but sometimes you will get overlap. So again, we're talking about a chronic ulcerative bronchitis, which is bronchiectasis. Now, to help us understand the process that leads to this destructive uh, airway lung disorder or disease, um, Cole back in 1986 developed the vicious cycle, which you see on the left hand of the slide. And if you look to the right, we come to 2018, and Flume basically came up with his version called the vicious vortex. If we go back to the vicious cycle, you'll see at the very top at 12 o'clock, there's impaired mucus clearance. And this basically brings to light, you know, inherited mucociliary disorders. For me and my practice, we may see pertussis, and that's the cause of the 100-day-old cough, and adults get it bad as well as children. If you look at the vicious vortex at 12 o'clock, again, uh, the primary problem is impaired mucociliary clearance. And if you follow the vicious vortex, clockwise, you'll get airway structure damage, and then you get unwelcome infection, little bacterial cities are born, and then inflammation. And it doesn't ever resolve. And what you have is this really chaotic, very dynamic, and just unforgiving uh, disease process, which basically causes necrosis. So the vicious cycle has been advanced to the vicious vortex, and we're going to see moving forward how this can provide you and I a target for intervention. But again, let's not only be disease centric in our conversation together, but let's also be very patient centric. The prevalence of bronchiectasis is more common in women than in men. Uh, 29 cases per 100,000 Americans annually. And as you can see in the iceberg on the far right-hand side, 500,000 have been diagnosed, but it's estimated there are 4 million undiagnosed patients living with bronchiectasis. And we'll see that, we're not talking about cystic fibrosis. We're talking about bronchiectasis by itself, typically after a severe pneumonia. And we're talking about overlap syndromes with a variety of disorders that are hallmarked by systemic inflammation, like autoimmune disease, even inflammatory bowel disease. So and the actual prevalence is likely to be much higher. this is just a hypothesis, but I think the reason why there's only 500,000 is that many of these patients are in their 60s, and that's when they start developing impairment because they are no longer able to adapt. So I think we need to diagnose earlier, recognize, it began sometime because by the time you typically see the CT scans that I'm going to share with you, the horse is out of the barn. But the key point, again, is to ask why not bronchiectasis when patients continue to cough? Because bronchiectasis is underdiagnosed, as I've tried to show you, and therefore undertreated. But even when it's diagnosed correctly with a CT scan, a high resolution CT scan, bronchiectasis is undertreated because we're relying on the patient to do all of the heavy lifting, the coughing. Did you know that the prevalence of bronchiectasis is up to about 50% in COPD and in asthma is about 35%? Now, again, you can find any article to, change, those numbers. And you may say, well, it's far less, Sam. And if depending on the article you have is true. But what is always true is that bronchiectasis is a clear and present danger. So, the key point number three and number four, true or false. Okay, the first key point. Is this true or false? Bronchiectasis hospitalizations are deadlier, costlier than those for COPD and for asthma. True or false? Make your answer. Now, I can't see you, but I'll assume that you've been in practice for decades and it's true. Okay, key point number four. Compared to those who have COPD or asthma alone, patients with comorbid bronchiectasis, the overlap, have increased risk of exacerbations, greater disease progression, that is loss of FEV1, and death. True or false? And the answer is that's true as well. So how do these patients, present? I mean, this is really the problem. All their symptoms are very non-specific, except for the cough. And my mentor Glenn Lillington told me that a cough is a sign for all reasons. But in the case of bronchiectasis, it's very true. This chronic productive cough that you see illustrated on the slide, usually we're talking about coughing for 8 weeks or longer. It's productive. Hemoptysis is not really that common. It's like 20%, if I use the 80-20% rule. But there are really a lot of recurring infections. And as many of you know, in non-cystic fibrosis, bronchiectasis, Haemophilus, it kind of trades places with Pseudomonas, but trades places with pneumococcus and other bacteria. Any bacteria wanting to, you know, thrive is going to do that. But this leads to debilitating symptoms. These patients basically, are going to gravitate more to the common diagnosis that you and I see in everyday practice, asthma and COPD. So key point number five, cough is the key symptom. Cough is both a symptom and a sign. It becomes a sign when the cough becomes chronic and it produces purulent phlegm, or if it brings up blood. Now, a clinical pearl, I guess this is key point number six and number seven. Uncontrolled asthma or COPD may be a warning sign of underlying bronchiectasis. You got two diseases. I have two fingers, two diseases. But also know, and this is key point number seven, patients with bronchiectasis are frequently misdiagnosed with asthma or COPD in 25 to 30% of cases. So we have a lot of misdiagnosis. And again, the only way to confirm the diagnosis, short of doing an autopsy like Lynette did, is to do a high resolution CT scan, or even the low dose CT scans that we use to screen people for lung cancer. You can sometimes pick up more severe bronchiectasis. But before we talk about a high resolution CT scan, let's talk about my favorite word, sputum. Okay. Actually, my favorite word is phlegm. I mean, phlegm is everybody's favorite disgusting word. But phlegm, for those of you who are students of medical history, phlegm is one of the essential bodily fluids. It's one of the four humors. Blood is one of the humors, phlegm is one of the humors, and I don't know what, I think I know what yellow bile is. I don't know what black bile is, but again, the Greek physician Galen basically described it. And this is, something that he developed from his teachings from Hippocrates. So this everyday disgusting word is sad, people don't want to talk about it. My ICU nurses, in the past when I was working in ICU, much prefer to clean poop than suction out phlegm from the endotracheal tube. And those of you who have been watching The Pit, I'm still waiting for Dr. Whittaker to be hit in the face by a goober. I don't know if that's going to happen the second season, but we'll see. But, phlegm is typically a water-based gel. There's no color to it. It becomes colorful when it's infected, and most bacteria are colorless, but when white blood cells come in and when they die, they release myeloperoxidase, then you get this Murray chart, sputum color chart, and mucus leads to plugging. And we know from, you know, multi-detector CT scanning, a study done by Dunnigan that was published in the Journal of Clinical Investigation years ago, I think it was 2018, that patients can have mucus plugging for years. And even if you inject them with triamcinolone, the mucus plugs, they don't go away. So mucus, okay, becomes phlegm. When you expectorate phlegm, it becomes sputum, and the color is associated with disease severity. The more purulent it is, the more likely. But again, purulent phlegm doesn't have to come from the lung. It come from the upper airways, the sinuses. So be worried that. But getting to one of the key messages to get home tonight is that airway clearance therapy has been proven to decrease plugging in patients with bronchiectasis on high resolution CT scan. And it really improves the outcomes that we hold many of the pharmacological interventions that are coming to the fore for prescription to try and give patients a fighting chance to live a better life with bronchiectasis. There's many, many causes of bronchiectasis. I'm talking about the non-cystic fibrosis. Going from left to right, you got, of course, genetic, cystic fibrosis, primary ciliary dyskinesia. And the most common one is post-infective, from pneumonia. That counts for like 20 to 40%. Then you got your autoimmune diseases like lupus, rheumatoid arthritis, and then Crohn's disease, inflammatory bowel disease, and ulcerative colitis. This was the inspiration for the three-word phrase that I shared with you earlier, the chronic ulcerative bronchitis instead of colitis, and GERD and aspiration. And I think the creators of this PowerPoint left out the word lung disease for the very last column on your far right because COPD, asthma, ILD, and allergic bronchopulmonary aspergillosis can be associated, of course, with bronchiectasis, with up to 50% of them are idiopathic. And what are key omissions from this slide? And I can hear many of you saying, hey, Sam, wait, what about tuberculosis? What about COVID? Yeah, tuberculosis, not that common, but worldwide, yeah, big time. COVID, particularly severe COVID if you've been hospitalized. But I can hear, Professor Brooks Kuhn say, what about alpha-1 antitrypsin deficiency? Well, that belongs in lung disease in the far right. But we need to also include lung cancer. Cystic fibrosis is not the most common cause for bronchiectasis. Post-infectious disease is. So how do you get the diagnosis? It's time honored. Get the clinical history. Ask that question. Why not bronchiectasis? And don't be shy to get a CT scan. Okay? If you suspect it, get a high resolution CT scan because the definition of the thin slices, 1.2 millimeter and sometimes smaller, will give you an idea of whether or not the patient's bronchi are normal, if they're cylindrical, if they're varicose, or if they're cystic, going from left to right. But many of you have heard me speak over the years. I think cylindrical bronchus, cylindrical bronchiectasis on CT scan, that's already late bronchiectasis. And varicose patterns, that's too late bronchiectasis. And when you become cystic, like the very last image on the far right, that's way too late bronchiectasis. What's missing on, this slide is traction bronchiectasis that you typically see in patients with interstitial lung disease, ILD, or idiopathic pulmonary fibrosis with lung honeycombing. And again, the things we look for on the chest CT scan is an increased bronchoarterial ratio. If it's greater than one, if the airway basically appears larger than the blood vessel that is in the same bronchovascular bundle, it suggests bronchiectasis. But again, that's the classic signet ring sign. But there are other signs that I use as well. I look for the visibility of the airways in the periphery of the lung, 1 to 2 centimeters from the pleural surface. And I really look for lack of tapering. Again, why not bronchiectasis? And when you basically, you know, have a clinical diagnosis and confirm it with the high resolution CT scan, then phenotype the patient, endotype them, and then conduct a clinical trial because every bronchiectasis patient is unique. Again, some of the things that you can order after your clinical history and your high-resolution CT scan, obviously, is your pulmonary function test. And you may see, an obstructive pattern. You may see a mix obstructive and restrictive. The DLCO may be low in these, and it really is attended with a very poor prognosis if it's low. The sputum culture is really, really key. And the reason why is that, if you look at the ABC, the old mnemonic, A stands for antibiotics. You need to find out what bacteria are growing and what the antibiotic sensitivities are. You got to look for not only, Haemophilus, strep, Pseudomonas, you got to think about Mycobacterium and Aspergillus. And of course, the blood test, that's how we search for, autoimmune diseases, immune deficiencies, IgM, IgA, IgG, and again, for the cardiovascular diseases, ANA, of course. And you got your anti-CCP, and you think about lupus, then you got to do a double-stranded, anti-double-stranded DNA. But I'm not qualified to talk about cystic fibrosis. But if you need to, again, that's the last thing on this slide, but very important to make correct diagnosis. And the prognosis for patients living with cystic fibrosis is so much improved, particularly the new therapeutic interventions compared to my experience back in the 1970s. It's just remarkable how medicine has advanced for the benefit of our patients. Okay, so um, let's go to the next slide. Ooh, we get to talk about airway clearance therapy now. That's fantastic. But before we get there, I have uh, two more key points I'd like to bring up. Key point number 9, exacerbations of bronchiectasis beget more exacerbations. And I want to quibble with the guidelines from the UK. Again, I could be wrong with this, but they consider action to take place if you have more than three or more exacerbations a year. But look what we learned from COPD. Even one exacerbation is detrimental to the patient. So I think we need to lower the number of exacerbations because that will be a call to action. The consensus definition of an exacerbation in bronchiectasis is an acute deterioration of 3 or more symptoms for more for 2 days or more, and a change necessary in treatment, like more bronchodilators, maybe antibiotics. This is very different from the definition of a COPD exacerbation by the Gold report. Very different, where the duration of an exacerbation is less than 14 days. Now, I'll let you basically deal with that. But exacerbation of bronchiectasis can last 30 days or longer. So these patients are really suffering. They don't see any daylight. And key point number 11, having a bronchiectasis exacerbation is the strongest predictor of a future exacerbation. But this is nothing new to you and I. We know this for COPD based on the ECLIPSE study that was published in New England Journal of Medicine. I think it was back in 2010 for COPD. So how do you prevent exacerbation, which is, I think, the major treatable trait? Because patients are falling down the staircase toward their demise, early death. And that puts all the symptoms in there too. You want to, reduce their coughing, reduce their copious sputum production, reduce their shortness of breath. That brings them to their knees. Well, airway clearance therapy. Now, Key point number 12. And this is from Professor Stephen Lomach from National Jewish Health. Uh, Professor Lomach will say, what are the three cornerstones of bronchiectasis management? What are they, ladies and gentlemen? Number one, airway clearance. Number two, airway clearance. And number three, you guessed it, airway clearance. And it's very important to take in this wisdom from Professor Lomach as we move forward. Again, we're talking about trying to target, and here's the vicious vortex. Airway clearance is the mainstay. It's you can have all of these new therapies, and they're going to help make a difference. Believe me. I mean, from azithromycin to the new drugs that really modulate the activities of neutrophil proteases. But again, it's very important to understand that that's not the whole picture. Pills and inhaled therapy is not going to solve all the patient's problem, but effective coughing and assistance with their coughing is very, very key to the patient's uh, prognosis and their quality of life. Pulmonary rehabilitation. Oh God. I mean, we saw the benefits during the pandemic. These patients with bronchiectasis, they will definitely benefit. And so again, if you have a pulmonary rehabilitation program like we do at UC Davis, definitely refer patients. There's a line, like everything else in this country, there's a line. Get them ready because they need to consolidate education to learn from you and I in the clinic or in the hospital. And it's just a key to also let patients see that they're not alone. You're not the only people in the world with bronchiectasis. Antibiotics. Yeah. Very important to rule out non-tuberculous mycobacteria because if you're going to use azithromycin Monday, Wednesday, Friday, or every day of the week at a lower dose, you don't want to use it because, again, azithromycin is one of the three drugs that you would use, to treat non-tuberculous mycobacteria. So you got to get a sputum culture, and people never want to look at sputum culture, never, you know. So it's very important. And as far as, anti-inflammatory drug therapy, all we've had for a while, and this is just my biased opinion, was azithromycin. But now we have, new drug therapies, and one in particular is it's not DNase, okay? Those who are thinking of DNase. It's the dipeptidyl peptidase 1 inhibitor that was FDA approved last year in August for non-cystic fibrosis bronchiectasis. So instead of ABC, I have a mnemonic to share with you. A mnemonic that Dr. Florence Chapar and Dr. Brian Morse and I published in Pulmonary Pitfalls. It was lies, damn lies, and bronchiectasis. And if you can remember the mnemonic, damn hello. I hope the FTC doesn't take me off the air, but damn hello. D stands for drainage, effective coughing, basically. A stands for antibiotics. M, mucus clearance. And this is where your airway clearance therapy really comes into play. N stands for nutrition. H stands for high frequency chest wall oscillation, as well as hypertonic saline. E stands for exercise, education, empathy. These are the three E's of pulmonary rehabilitation. There are two L's in the word hell or hello, damn hello. That's a LABA and a llama, and O stands for oxygen. So damn hello. We can replace ABC with that. I mean, airway clearance, people will say, oh, just cough harder. It's not so easy when you're the patient. And if you look at the goals of airway clearance therapy, they're the same targets for pharmacologic therapy. Improving quality of life, going from bottom to top, decreasing symptoms, reducing exacerbation, which I basically pinpoint as the highest priority, and preserving lung function because that's really key to long-term survival. Now, I don't intend to show you huff coughing or autogenic drainage. I don't intend to show you, percussion. I used to do this back in the 1970s, you know, on patients. They didn't like it, You put them on their side and start pounding on their chest, and next thing you know, all this phlegm comes up, you know. And you have to do it often for them to actually benefit. So this leads me to key point number 13, lucky number 13. Beware of the great illusion. The single biggest handicap in bronchiectasis care today is the illusion that the patient's cough is effective when it's actually not. There's a lot of physics involved in coughing. The velocity of the air that's pulsed out of your airways is like 50, 60 miles per hour. Maybe I can't use it on my Honda Civics, sadly. It's very important, basically, to understand that patients need to know how to cough. And when you look at all these airway clearance therapy, and we're going to go on to VEST very shortly, and as well as in fact, let's go to the next slide. You see on this slide going from left to right, the oscillating positive pressure, expiratory pressure valves, the oscillating lung expansion devices, and then you have the high frequency chest wall oscillation. I often call on my colleagues across the United States, and I remember calling George Solomon at the University of Alabama at Birmingham, and I wanted to learn more about bronchiectasis and what I need to do best. And he happens to have a center of excellence at UAB. And he told me, George told me, Sam, you haven't done airway hygiene until you've done high frequency cholesterol oscillation. So I didn't abandon, the acapella valve or the aerobica. I started, using vest therapy, and I asked the patients to teach me, and they taught me tremendously. And what we're talking about is external oscillation. This is very different from, traditional percussion and drainage. It's definitely different from the oscillating positive expiratory pressure devices, the acapella valve and aerobica, and very different from, the oscillating lung expansion, where in my mind, there is some risk if the patient is unable to remember how to do it safely, because you can get volume trauma and barrel trauma if you're not careful. The whole idea of high frequency chest wall oscillation again is to use physics. And here, hope I don't spoil your trip to In-N-Out Burger, but I want you to think of ketchup. Okay, ketchup basically in a bottle, particularly Heinz ketchup, you can't get it out of the darn bottle. In fact, in the old days at home, I used to stick one chopstick just to get it running. Because once the ketchup starts running, it's fine. But when it basically sits on a plate or on a French fry, it begins to solidify or become gel-like, you know? And so what we're doing is taking our understanding of this gel that we call phlegm, this hydrogel. We're going to basically use high frequency chest wall oscillation to cause oscillating ripples. And this will shear the mucus away from the wall. It will basically thin out the mucus as a consequence. And then the mucus is propelled to the large areas where you can expectorate. And phlegm, when it comes out of our body, becomes sputum. And what you see on the left-hand side of the slide is a video. And see if I can activate it. Here we go. And what you see is this bladder, that wraps around the patient 360 degrees, and it compresses between 5 and 20 times a second, and it causes these vibrations. And it's not working now. Darn it. Let's do it again. It was working before, ladies and gentlemen. It was working before. And what you see is the lung moving, back and forth. Oh, there we go. And this simulates a natural cough, because what you're doing, you're taking the air that's in your lungs and you put it behind the mucus that's stuck on the airway wall, and you're going to propel, you're going to make it thin, and you're going to shear it off using this particular device. Okay. And the benefits of high frequency chest wall oscillation comes from very, very small studies. But again, let your experience teach all of you. I'm talking about studies that, number 59 patients versus 65 patients. Some were prospective, some were retrospective. But here, what you see here is a prospective study. And you see, almost a 60% reduction in antibiotic prescriptions, almost a 60% reduction in hospitalization, 60% decrease in emergency visits from, this study by Sievert using, you know, high frequency chest wall oscillation. And there are basically, three vests that are most popular. They're both, not both, all three are different. And you really have to acquire an experience with all three. Now, again, George Solomon from the University of Alabama at Birmingham published his retrospective study, and he came up basically with an algorithm for caring for patients who live with bronchiectasis. And what you see to the far right in the square, you know, you assess the patient, you give them bronchodilators, mucolytics, consider giving them macrolides, either azithromycin or clarithromycin. And in this case, they used high frequency chest wall oscillation, and they found a, a difference in outcomes using high frequency oscillation compared to no, just huff coughing. And huff coughing, it is great, but remember, high frequency chest wall oscillation cannot replace huff coughing, and huff coughing cannot replace high frequency chest wall oscillation. So you need both. So this is why it's so important to make certain that you have on your team a registered respiratory therapist, which is what we do at UC Davis. They are just national treasures for my patients and for me and my colleagues. So a patient, they don't have to be elderly and wise as this lady is portrayed. They could be young, So don't let age and textbooks and the published literature tell you that, oh, the average age, the mean age is 65. If you have, if you can fight the indifference, you will diagnose it early by getting that high resolution CT scan sooner. And then you can initiate. And, oh, I forgot. Oh, stupid, Sam. Smoking tobacco and likely smoking marijuana is a risk factor for developing bronchiectasis. Not surprising. I mean, it really does a number to the airway cilia. You get mucus retention. So again, please, get people to stop smoking. I can't do anything about air pollution though. Okay, let's talk about overlap. We're coming almost to the end and your great weekend. Again, overlap with COPD. Nearly 50% of patients with COPD will have comorbid bronchiectasis. A lot of people say, oh, that's wrong. It's no more than 8%. A lot of these patients have pulmonary hypertension, and that's why the airway looks bigger than the blood vessel next to it. But again, there are a lot of articles that suggest otherwise. And I'll ask you to read the literature, not believe what I'm telling you. But bronchitis prevalence does increase as COPD severity increases, and it may be the reason for why these patients are frequently having acute exacerbations. And I want to thank the US government for naming COPD as one of the diseases that they would penalize hospitals for readmissions of COPD patients after exacerbation. Because we wouldn't be talking about COPD or bronchiectasis if it wasn't money, to be lost behind it. So again, don't forget, ask why not bronchiectasis? And again, when it comes to non-tuberculous mycobacteria, uh, that is together with Haemophilus, influenza, and, streptococcus, bacteria that you can find. This is why it's so important to get a sputum culture. But nobody, you got to get it in the morning. That's the best time. Some of you who are older and wiser, you may remember going, doing your residency to all the hospital bed and dropping an NG tube into people's stomach and basically pulling out the residua in the stomach. Because that's where all the AFB were. That's how we used to do cultures back in the day. No longer now. But again, in addition to COPD, non-tuberculous mycobacteria, I mentioned earlier, the collagen vascular disease, the inflammatory bowel disease, asthma, lung cancer, alpha-1 antitrypsin deficiency. They all basically, you will, if you practice long enough, you will basically have that, and you want to be prepared to help that patient. So in summary, I also include a call to action, but in summary, remember, 500,000 are diagnosed, and maybe they're the lucky ones, but there's another 4 million patients who are avoiding having to see you and me because they don't want to, but also because we are just overwhelmed with all the documentation, the electronic medical records. Just think about those patients who need frequent antibiotic use. I mean, if they have more than, you know, one or two exacerbations, definitely if they have two exacerbations a year, think of bronchitis, get a CT scan. Identification of bronchitis is essential to providing targeted therapy. You know, damn hello, forget the ABCs. It's really about, recognizing too what Professor Lomach has tried to teach all of us, airway clearance, airway clearance. So what is your role? Here's the call to action. What are you going to look for? And if you have a patient with bronchiectasis, what's your airway clearance therapy management? And here are resources, and I think this PowerPoint deck will be available for all of you to review. The COPD Foundation is always a resource. And with that, I want to wish all of you a very happy weekend. I was told I only had 45 minutes, and darn it, I did it. So, Jason, I'd like to open the line to questions, and I pray to God I have answers.
Wow, thanks, Dr. Louie. Both educational and entertaining, and a lot
I
of
don't mean to
great
be entertaining, Jason.
pop culture references. It keeps us on our toes. It keeps us focused. We appreciate it. I'm going to jump
Thank
right
you.
in and read our first question. We've got a few already lined up here. It's a bit of a long build up, so I'm going to just get right to it. I work at Alaska Native Medical Center. I appreciate your emphasis that bronchiectasis is underdiagnosed. One reason is that if patient smokes, physicians are quick to label them as having chronic bronchitis and often don't pursue additional evaluation. This, of course, leads to gross undertreatment as the only treatment rendered, and where the advice is to stop smoking. There's also, in my opinion, a component of class and socioeconomic bias. Upper class, well insured patients are more likely to get a CT scan than underinsured, poor patients. Policy experts love algorithms. My question is, what do you think of recommending, as part of a quality measure algorithm, a recommendation that if the patient has been seen by their provider or been seen in the ER more than 2 times in 1 year for exacerbations of bronchitis, they should have an HRCT to look for underlying structural lung disease?
I think that is an outstanding recommendation. If it is a gentleman who's a outstanding pulmonologist in Alaska, I think I know his name because he mentored two of my fellows at UC Davis, but I forgot his last name. I think it started with the letter R, I believe. But thank you
John
for.
Clark?
Hmm? Oh,
This
wrong guy.
question came from John Clark.
Okay, well, John Clark, he's also outstanding. But there's another pulmonologist who left Hawaii to work in Anchorage, as I believe. But what Dr. Clark has proposed, basically underscores what I was trying to say earlier. This is not only a disease of the elderly. You can diagnose it early, and when you diagnose a disease earlier, there's a greater chance you can impact. Some people will say, why are you, why are you throwing water on the house? It's already burned down. And some people will say, that's what COPD is. Well, that's what bronchiectasis is too. But if you need frequent antibiotics, you know, I think that's a reason to ask why not bronchiectasis. And I think Dr. Clark proposed a study that can probably lead to more patient safety. The question is who's going to pay for that study. But given the disparity in the people who are diagnosed and undiagnosed, I think it's a very worthy idea that needs serious review. Thank you, Dr. Clark. That was awesome.
All right, next question. Do you like to use Donray's alpha with this particular population?
I'm not familiar. I mean, I see a fair number of patients with bronchiectasis, but I'm not familiar with that. Maybe you can teach me. What is that?
All right, great. Well, we'll see if we get some follow-up
Okay.
information. And you can see these questions that I'm reading aloud to you in the Q&A if
Oh,
you're
really?
not looking
I
at
have to
them.
find that box.
That button, that's okay. And I'll keep reading along as you're doing that.
I mean, I would
Okay.
refer, our patients with bronchiectasis to my colleagues, Dr. Florence Chow-Chapar and Dr. Brian Morrissey. They really have a center of excellence at UC Davis, and I'm more or less the past, ladies and gentlemen. I'm trying to stay relevant in the present. But
Uh,
bronchiectasis is everybody's problem, and you'd be surprised, how many cases you'll run into. I remember when Professor Morrissey, when he finished his fellowship at National Jewish and came back to UC Davis to be one of our professors, he asked me, "Hey, Sam, how do you see allergic bronchopulmonary aspergillosis often?" And I said, not that often. And after about 3 months, they were falling out of the sky, literally. I mean, everybody had ABPS. So again, you can't find trouble unless you look for it. And again, getting back to what Dr. Clark is suggesting, there's going to be maybe that we can use artificial intelligence in a productive way and see if it's a worthy study to do. But that's something I think that comes from, Dr. Clark's empathy, for these patients, because once they get to, cystic bronchiectasis or, cylindrical bronchiectasis, it's already late and way too late. You know what I mean?
thank you. Next question. I've heard that people with bronchiectasis have layering sputum. Is this true?
I heard of that, but I don't know if I can quote an article. Yeah, again, the mucus is typically clear. I gave a lecture to the Trudeau Society, and I couldn't find a good picture online, basically, for mucus. So I decided to show a fried egg sunny side up. Okay. And the yolk, of course, is all the dead white blood cells and bacteria. And what you see on the outside, basically, is the mucin. As far as layering, um, you know, I'm not sure, but maybe our colleagues is talking about the different components of mucus. There is a particular mucus, a mucin 5AC, which is particularly nasty. Again, I think we all have it, but people with bronchiectasis have much more. People with COPD have much more. And this allows me to bring up the point that not answering the question, bring up the point that mucus plugging is associated with early mortality, not only in COPD, but in asthma. That's been shown recently. And I can't quote chapter and verse for bronchiectasis. As far as the layers specifically, like no Neapolitan ice cream, I would have to ask you to educate me again.
Thank you. Next question. From your opinion, which is more effective, IPV or CPT vest? We have providers ordering both. Is that beneficial?
Um, you're talking about IPV or CPT? I mean, I'm
It said
familiar with.
they're asking which, if you have an opinion on which is more beneficial, the IPV or CPT vest.
It really is dependent on the patient. It really is. It's like I said earlier, they're different vest technology. They're not all the same. And so I will go with the patient.
Thank
Try
you.
try all the technologies to help and the devices to help the patient.
Next question. How common is bronchiectasis in pediatrics and how early can it be diagnosed?
Oh, okay. I'm gonna have to go to you know, open evidence, up to date, the literature, PubMed to find the answer to that. I don't know. I don't know. But again, um, as I said at the very beginning, Jason, and to our colleague who asked the question, it used to be common for orphans and orphanages to get bronchiectasis from repeated pneumonia. So it all depends. Going back to the very long question from Dr. Clark, a lot of social economic factors come into play. If you are in a neighborhood, a community where a lot of indigent, yeah, you're going to see more of bronchiectasis as well as more serious chronic diseases. And this is why it's so important to really reach out to the community and to educate the community about these different diseases, which what we're trying to do here at UC Davis with these boot camps. we hope to have a boot camp for bronchiectasis very soon. I don't think Dr. Morrissey and Dr. Charles you probably know that, but it's in my brain. Is an idea. That'll give me my ABCs, asthma, bronchiectasis, and COPD. Because the approach the is very similar, but again, as I said earlier, bronchiectasis is a much more deadly COPD to have and to deal with because pneumonia and hospitalizations are more prevalent. The mortality is almost 1% higher than for COPD, and so that should give you an idea of how serious bronchiectasis is. Of course, I'm talking about the non-cystic fibrosis bronchiectasis, and of course, if you have bronchiectasis, whatever you have, always try and treat the underlying disease. If it's lupus, if it's inflammatory bowel disease, Crohn's disease, always treat the underlying disease.
Thank you. Next question. First, your lecture was absolutely superb. How often do you use VEST? Should patients with MAC be prescription in a center specializing in this disease?
Oh, that's a good question because I have tried for years using the acapella valve. It's a nice device. It's looks like an avocado to me, and for some patients it works, but I have really gone over to using high frequency pulsal oscillation and vest therapy. My conversations, not just one conversation, several conversations with George Solomon at UAB, taught me lessons. And I don't want to basically mess around because if I do, the patient may have another exacerbation. As I said earlier, these patients are falling down the staircase, but these people with bronchiectasis as well as COPD, they're falling down the staircase to begin with, whereas asthma is far higher. They haven't lost as many FEV1s. So I use vest therapy. But I do have to give them a trial, and I give them no more than a trial of 1 or 2 weeks with an acapella valve, an aerobica, and if they continue to have symptoms, uh, we can do surveys of their symptoms. If they are not better, then I'll go straight to vest therapy. But again, for bronchiectasis, you have to have radiographic evidence of bronchiectasis, and I would, as pulmonologist, read your own CT scans.
Wow, thank you. Great answer. Next question. Should we ignore the study showing no benefit from 7% saline as part of airway clearance?
Yeah, that's a really a hot topic. I mean, these are people who specialize in bronchiectasis, Jason. I mean, 3% and 7% are not inferior to each other. It depends on what works for the patient. But 10%, I can tell you, is really hard to do for our patients. Okay, and the thing is, if you can do without the saline, even better. So again, just because this mnemonic has the age for high frequency chest wall oscillation, hypertonic, it doesn't mean that you have to do it. But there are other things the patient needs to do: nutrition, hydration, all that, and upon rehab. That really makes a heck of a difference. So and me personally, I'm not a big fan of hypertonic saline. I know that's blasphemy. And, if Professor Morrissey was listening, he'd probably skewer me right now. But that's the way I practice. That's my experience. But I don't see cases as severe as he and Florence see in their bronchiectasis clinic.
Thank you. Next question. First, thank you, Dr. Louie, for a delightful presentation. I am currently seeing steroids prescribed to patients with bronchiectasis exacerbations in addition to antibiotics. What is your opinion about this practice? I have to admit that it seems to prolong recovery and increase purulent phlegm.
Our colleagues set a trap for me. Steroids and especially inhaled steroids are really, have no place in treating non-cystic fibrosis bronchiectasis unless you have a patient who really has the biomarkers that convinces you that there is a treatable trait, in this case, high levels of type 2 inflammation. And again, a case in point, ABPA, it's not only, there's probably neutrophils, but there's more eosinophils. And I remember reading a letter. There were like 12 cases of non-cystic fibrosis, bronchiectasis, and they were on inhaled steroids, and the idea, of course, is that steroids, they may actually promote viral infections and bacterial infections. So the question posed by our colleague is really important, but there is benefit. I mean, this is why the practice of medicine is really an art form. But these patients in this letter to this one of these allergy journals show benefit from these patients being treated with dupilumab. Um, and so I think there is a place for biologics, but you have to be very careful. It's not for all patients. And again, the majority of patients who have non-cystic fibrosis bronchiectasis have a neutrophilic profile. I mean, and again, it may not do very much about the Pseudomonas some of these patients have, but there are in play now studies looking at inhaling, antibodies against Pseudomonas, and there are other therapies, but I would refrain from using inhaled smoke. But this requires all of us to be certain that asthma does not exist, or if the patient basically has no evidence of eosinophilic COPD. And sometimes, you really have to, go back to the medical record and see, where the blood eosinophil count has been. There is sometimes, there's a no concordance basically with the airway eosinophils with the blood eosinophils, but the blood eosinophils will be a good place to begin your investigation. If it's 300 or greater, then again, I would give a very short course of inhaled steroid and see what happens. The darn thing about it is that your colleague who asked the question, and I know, and all the members of the California Thoracic Society know that if you get a viral infection, your eosinophil is going to go high. So this is why it's so difficult. You can't treat bronchiectasis or that matter asthma and COPD with inflexible algorithms. You have to basically be ready to change your approach and change your treatment depending on how the patient responds to your treatment. But prednisone is a no-no in bronchiectasis, in my opinion, if it's truly neutrophilic.
Thank you. I'm going to jump ahead two questions. There's a follow-up that's related. Is there a role for alternating monthly antibiotics in very frequent exacerbators?
Not that I'm aware of. I think I would discourage that. I mean, as everybody knows at the California Thoracic Society, azithromycin, 500 Monday, Wednesday, Friday, or every day of the week, that's not being used for its antibacterial activity. It's used for its anti-inflammatory properties. But I would, refrain from using antibiotics for fear of resistance. But again, that's a question I would defer to my esteemed colleagues, Dr. Chapar and Dr. Morrissey, who have far more experience than I have.
Thank you. Next question. Could you please comment on pediatric presentations, non-CF, and indications for HRCT and sputum cultures?
Oh boy, if the little girl or little boy basically, frequents the emergency room more than twice a year with upper respiratory tract infections, that settle in the lung, I would consider getting it. I don't know what the official recommendation is, to be honest with you, for children. My practice, as you know, is primarily in adults, but you got to look for other comorbidities in that instance. You know, um, Gastroesophageal reflux, pulmonary aspiration. You got to treat that. And so, getting a CT scan doesn't really, help other than to confirm the diagnosis. You got to treat the patient and really involve the parents, the non-paid caregivers, into developing a plan using shared decision making.
Thank you. There's a follow-up question from the same person. I'm hoping I'm going to say this correctly, but I might need your help here. What are the implications of chronic serratia or serratia colonization of airways?
I don't know. Serratia is a nasty gram negative. They used to, throw it in the air in San Francisco and check the wind currents. I remember seeing cases of serratia endocarditis when I was a medical student in San Francisco. But that's a very bad gram negative bacteria. Very quickly develops resistance. I hope the lady or the gentleman who asked the question doesn't have too many patients with serratio. It's very uncommon. I mean, it again develops this very pretty pink pigment. That's what we you know think of when we think of serratio marcescens. So I have no good answer. But this is
Well,
why,
thank you.
I want everybody who's listening, I think what I try to share with you is, my pitfalls in my career. When I don't know something, I call somebody who does. It's really quite delightful. You'll be surprised how friendly people are. Now, some people, will email, okay, and that's okay too. But I think it's very nice to talk because, many of us, just use technology, but it's so delightful to, have a conversation, a real conversation with one of our colleagues. And you learn every time you call somebody who is smarter than you. So that's what I do because I want to learn. So I always call people who I think are smarter than me.
Thank you. All right, round in the home stretch here. One last
Oh,
question.
this
What
is
are
this
your
is this typical for the questions? I mean, this is like,
No, this is
oh,
the most active, engaged group we have probably had this entire year, including
the year
last
just
year.
started, Jason. So it's only January.
I'm loving it. I know it's late, but I just want you to know you've got about 70 people sticking with you right now.
Oh,
And
good heavens.
so
Well,
this
Happy New Year to
is
everybody.
exactly what we have, always dream about with these educational opportunities. So here we go. What are your thoughts regarding the benefit versus harm of inhaled corticosteroids in non-CF, non-NTM bronchiectasis patients?
Again, I would ask myself, what am I targeting with the inhaled steroid? And if it's the eosinophil, I want to accelerate their early death or apoptosis, then I go ahead, So it's kind of tricky. I mean, if I lean on my experience in asthma and COPD, if the blood eosinophil count is 300, 400, 700, oh yeah, I'll use an inhaled steroid. Even though the patient has bronchiectasis, he or she may have comorbid asthma or COPD. But by all means, get these people with asthma and COPD to stop smoking cigarettes. Or in the last 43 years, I've been trying to get people to move out of Sacramento without any luck at all, because Sacramento, oh God, the air is just a trigger. The environment is a trigger for exacerbations. So again, when you use any medication, ask what you're targeting. So if you're using inhaled steroids, are you targeting the neutrophil? No way. Are you targeting the lymphocytes? Maybe. But you definitely are going to try and target and the benefits from the inhaled steroids should be evident clinically after about a week, sometimes within a day. I mean, steroids have other effects. They cause vasoconstriction, and that will help reduce edema in the airways. But
Thank you. I'm going
people can
to
get more, viral infections, upper respiratory tract infection, and so it'd be like me cooking in the kitchen. You don't want to videotape that.
thank you again. All right, we have one last question since we're way into overtime here, but I know until we let everyone go, we're going to get one more. This is an important one, I think. If the condition gets worse despite treatment, do you ever consider surgery or lung transplantation?
Oh, yeah. The textbooks do talk about that. And back in the 70s, I learned that you can basically take out a segment, but you really need a really excellent surgeon to do that. And you want to make certain that you tried everything else. But if somebody needs surgery, as I've said to many of my fellows, make friends before you need them, you know. They know too, surgeons need us. And so work together as a team. The reason why I use the phrase interdisciplinary, Jason, in the learning objectives is because multidisciplinary means you can wash your hands and leave. But this is why it's so important to always engage your colleagues and call them up, see how they're doing, and say, hey, can I bounce this case off for you? But the surgery and lung transplantation, I've never had in 43 years encountered a patient who had lung transplantation for bronchiectasis, but I know it's been done. I know it's been done. But as the lady or gentleman who asked the question, you know that the prognosis for lung transplant it's not like for kidney transplant. So it's the opportunities to really make a difference. passed a long time ago when the patient had early bronchiectasis or, you know, but most of the time when we see it, you know, you can see it from yards away, that's exaggerated, but you can see it, a few feet away by looking at a slice of the CT scan. I mean, bronchiectasis literally destroys the lung. Where were we? Again, I don't want to use it, but I'll say it to end, neglect you know, uh, because we're working too hard. You know, it's having to fill out everything. The type. It's exhausting. We need to spend more time thinking, and so maybe we can employ artificial intelligence, but I don't want to give AI a chance. I guess I'm still fearful of Terminators, Jason.
Well, as we wrap up here, let me just say first, thank you for giving us all a lot of extra time tonight. As you
Oh,
can all
it's
see,
really a pleasure. But I realize I need to go back to school. I need to learn some more from your colleagues at CTS. And again, Happy New Year to everybody.
Dr. Louie's email is on the screen. If there was a question we couldn't get to tonight, he's incredibly generous with time. And if you'd like to send him a question, that's a way to do it. I'll end with agreeing with one of my favorite comments that I saw tonight, which I completely agree with. And that person said, Dr. Louie is a national treasure.
Oh, God.
Dr. Louie,
Thank
we
you.
really, really appreciate you and thank you so much for your time. I also want to give another thanks to SmartVest by Electromed for their support and dedication to an event like this. Education is such an important part of our society and our community. These webinars all started from a need and as COVID became a reality, and they've continued to be an incredible resource for our community. So thank you very much, SmartVest by Electromed, for helping make tonight's educational presentation a possibility. Thank you, Dr. Louie. Thank you for our community. Please get on with your weekend, and we hope to see you at a future Friday evening educational webinar. And most importantly, I'll sign off with just saying, please, if you don't know, the California Thoracic Society will be hosting its annual education conference this coming March 12 through 15 in Monterey, California. You can find out more about it at our website, calthoracic.org, where you'll have an opportunity to meet, network, and spend time with amazing colleagues like Dr. Louie and others. So we hope to see you there and or at a future Friday evening educational webinar. Thank you and have a great weekend.
Thank you, Jason. Thank you, everybody.
Yeah,
Have a good weekend.
thanks again.